Hello, everybody. Good afternoon or good morning, depending on where you are. So indeed, I'm Joke Borzée. I'm a PhD student in business economics. So I have a different background compared to most people, I think, here in this call. But my PhD is indeed focused on value-based healthcare and more specifically on linking the different health outcomes to the different treatment costs necessary to achieve these outcomes. So in value-based healthcare framework, the concept of patient value is a key concept and is defined as the outcomes divided by the costs. And today I would like to talk a bit more about the denominator of this equation being the costs, which is usually being calculated using the time-driven activity-based costing approach. And we did a research where we applied this methodology to a psoriasis setting. So we focused on an integrated practice unit at the University Hospital in Ghent, where they not only treat psoriasis itself, but also the related comorbidities. So let me briefly start by explaining what time-driven activity-based costing entails. So it's a management accounting technique where you basically only require two different parameters to get to a total cost. The first is a time estimate of a certain activity, so a different step in a treatment pathway, for instance. And the second parameter is a cost per time unit, which we call the capacity cost rate. Very important about time-driven activity-based costing is that it looks at the true cost of treatment rather than using claim data, for instance, or looking at the charged costs to the patient. So it uses financial data from the hospital itself. And we see an increasing trend in time-driven ABC applications within the healthcare sector, mainly due to because it can capture the complexity that is necessary within the healthcare sector. It's also easy to update in case the treatment changes, in case the time changes or a cost changes. We don't need to update the whole model, but we can just look at that step specifically. It also allows us to incorporate patient differences in their treatment pathway or different characteristics that influence the costs by using time equations. And as I said, it's the recommended method within the value-based healthcare framework to measure the treatment costs of a patient. And Kaplan and Porter have developed a 7-step framework to apply such a methodology within healthcare for a medical condition. And that's exactly what we also did within the psoriasis setting within the integrated practice unit. So I will go over that, how we did it, and also why it's important to have a measure of costs. So we focused on psoriasis as a medical condition together with its comorbidities. And the first step we did was to develop detailed process maps of the different treatment pathways that are possible within the clinic. We did this through direct observations, but also through face-to-face interviews with the different health providers involved. And actually, the goal of these process maps is to display all the possible treatment pathways that a patient might take within their treatment. So it should showcase all the relevant activities, but also the different resources that are involved within each of these steps, together with a time estimate of how long they are involved. For these time estimates, we used exact time measurements for the consults within the dermatology unit, which were measured through an app called Macy. And for the other time estimates where we could not directly follow the patient to its consultations, we used time estimates provided by the healthcare providers. So this is an example of a process map that we developed specifically for a consult within the dermatology department. So how it can be looked at is that each box represents a different step within the pathway. The color displays where it's taking place. And the box at the right bottom, the color represents the personnel that is involved, while the number inside the box gives an idea of how long that resource is involved. And then we can see that the patient starts here in the corner, it makes an appointment, and then there are some administrative steps, and then the patient might take different pathways depending on the characteristics or the treatment choices. For instance, here, whether a biological needs to be started up will result in different steps in their treatment pathway compared to a light therapy, for instance, needs to be started up. So how it can interpret it is that this box, so this would happen, for instance, the course to self-administer the syringe would happen in the hospital. The 30 in yellow represents that a nurse will be there for 30 minutes with a short supervision of the dermatologist of 3 minutes. So this is how a process map can be interpreted. We also see at the end that the patient might be referred to another department to get treatment for its comorbidity. And when there's a plus in the box, it means that there's an additional process map available to look at the treatment in detail. Now, once we have these process maps and we have an idea of how the treatment might look at, we also want to put a cost to the treatment. And this is done by calculating the capacity cost rates or a cost per time unit for each resource that is involved. And this is measured or calculated by dividing the annual cost by its practical capacity. And for annual cost, for when it's the resource is personal, we look at the annual salary cost. For machinery and equipment, we look at annual maintenance costs plus the depreciation costs. And we divide this by its practical capacity. And this means the productive time that is available to perform the intended activity, which differs from theoretical capacity as it takes into account that not every resource is 100% productive or can 100% devote its time to the specific activity itself. And then here I come back to my example, so we can combine the process map with the costing information. And then we can look at a specific patient. For instance, here in yellow is a possible path that the patient might take. And by then multiplying different time estimates with the different capacity cost rates, we can actually calculate the cost of that specific pathway. So for instance, here the dermatology consult would result in a total cost of 88.8 euros. But we also see, for instance, here that the patient is referred to a rheumatologist. So then we also look at a process map over there to see what path the patient took there or what steps were performed in the pathway. And then we can, again, using the same methodology by multiplying time estimates with the capacity cost rate, it gets to a total cost of, in this case, 54.91 euros. And that's actually how we calculate this cost for all the patients. But now what can we do with these costs, or how can we use it to improve processes? Well, first of all, developing these process maps, it's already a very efficient way to look at the different steps in a pathway, but also to identify redundant or repetitive tasks, especially if the patient needs to move through other health providers. There might be some repetition, where it's actually might be easy to identify some non-value adding activities, or like what we call them waste in the process. The process map also given a nice way to showcase actually the expensive steps within a treatment pathway and to put attention to that. And then it might be considered how to improve these different steps, for instance, by task shifting, as was said earlier as well, by using a nurse instead of a doctor for certain tasks. So already the first step of this methodology can already provide some indication for efficiency improvements. Next, a bit less related to the cost itself, but to the time estimates. By registering, you can also improve processes. For instance, we looked at the appointment schedule or the consultation schedule that was used to give a time to the patient on when to come to the hospital. So we looked at the foreseen consultation duration versus the real duration that was measured, and we noticed some inconsistencies there. So what we did is we set up a simulation study in which we actually looked at different alternatives for scheduling the patients. So for instance, already the sequencing of the patients, so new versus recurring patients, has a big influence on, for instance, the idle time, the waiting time, and the overtime of the clinic. So actually patients with less variability in their time duration should be planned at the beginning of the schedule compared to more complex patients or new patients that require more time or more variability in time should be more scheduled towards the end, for instance. Now, of course, we also used it to calculate a cost per patient. So in our study, we looked at 50 different patients that were treated in the IPU, and we get to an average cost of 390 euros. But we also see a large variation within costs ranging from 160 to over 1,000 euros for the treatment of a patient over a period of 6 months. And now, of course, once we have these costs per patients, we also want a bit to understand why these costs vary so much between patients. And therefore, we looked at different patient disease and treatment characteristics that could possibly explain some of the variation. So for instance, for patient characteristics, we looked at the age, the sex, the quality of life. Disease, we looked at the severity, the comorbidities, and of course also the prescribed treatment. Now our sample size was rather small. It was only 50 patients. So right now we're still collecting more data to improve the results, because we could not draw any statistical evidence or make claims about causality between the factors and the costs. But the results suggest at least some type of correlation between the age of the patient and the total cost. So there's an upward trend when the patient is older. Also, the more severe the psoriasis is, the higher the costs are. And of course, as could be expected, multimorbidity increases cost significantly, with having more than 4 comorbidities results in a total cost increase of 70%. And now finally, what we did with these costs is that we compared them with the compensated cost under a fee-for-service system. So we used the time-driven activity-based cost, which we call the true cost, and we compared it to the claim data. And here we actually made specifically a distinction between a cost that was related to traditional psoriasis care, so not taking into account the screening of comorbidities, for instance, or the other tasks related to comorbidity treatments. And on the other hand, the costs that were specifically for the integrated practice unit, so the costs that were necessary because they wanted to integrate their treatment. And we found that only 50% of the costs that relate to integration are compensated for. So there's a large mismatch between the fee-for-service system and the aim to stimulate integration within healthcare. So also within the value-based healthcare framework, they propose actually instead to use bundled payments, where the health providers receives a lump sum of money that should actually cover the entire treatment pathway. But of course, the design of such a bundle is very complex. But studies like these, so the accurate costing representations are actually necessary to come to such kind of system instead, but also to understand the different risk factors that influence the costs in order to also incorporate them within the bundled payments, so that each patient with its own complexity can be treated accordingly. So I hope I made it a bit more clear on how you can calculate costs within healthcare or dermatology in specific, and how you can also use the results of such a study to improve processes.
Okay, well, thank you so much for that. I guess we can, Elfie and I can come back and sort of, any questions for this great lecture just now? This is sort of how we should really be modeling things properly. Maybe I could just ask you, so a slightly tongue-in-cheek question. Why is it more expensive to see a dermatologist than a rheumatologist?
Oh, that was just an example. I didn't look at the different steps, but it might be due to the specific cost of the dermatologist within that hospital, for instance. But I think also the example that I showed now, the rheumatologist, not a lot of steps happened there. So it wasn't incorporating the cost of the tests, for instance, that were performed there. And also with the dermatology, also the cost of the nurse was included as well. So it was both a nurse consultation and a doctor consultation.
Yeah, so because I was part of the measurements, it's true that in rheumatology, they work in a classical Belgian way, which is the patient is seen by a doctor for 15 minutes. And here in dermatology department in our hospital, we work very integrated with a nurse and a dermatologist, also screening for comorbidity, having a lot of attention for the psychosocial aspects. So I think you can see that the integrated approach might cost per consultation more next to compared to standard of care, just a short doctor consultation. But what we want to show, of course, is that if you work very thoroughly, very integrated, that on the long term it will save you extra consultations or emergency consultations, or the frequency may lower. So that's the idea about the measurements that we are doing here in the hospital. So maybe that makes it more clear.